Face Forward Media. This is Healthcare Musings. I'm your host, Dr. Hassaballa. Welcome to Healthcare Musings, everybody. Happy to have you with me. Okay, this is the first in a new series on Healthcare Musings called Dr. H's Verbal Hassaboluses, where, these are my rants. And one thing that is so annoying to me is the system-based note. So I want you to imagine you're in the office or in the hospital, and a patient or a patient's family member says, "Hey, so what's wrong with me, or what's wrong with my family member?" And so you proceed to say, "Thank you for asking. Let me tell you, neural is doing great. CV, everything's fine. Pulmonary, no problems. Uh, um, GU, great. ID." You have a urinary tract infection and we're giving you antibiotics. Endo, everything looks fine. Uh, Musculoskeletal, everything's great. No one would do that. No one would do something like that. When a patient asks, "Doctor, what's wrong with me?" or when a patient's family member says, "Okay, so what's wrong with my loved one and what are you doing about it?" You give them the diagnosis and then you tell them what you're going to do about it. And so our documentation should reflect that exact same thing. And the new documentation rules do not encourage a system-based note. They don't even mention that at all. It's medical decision-making. And the medical decision-making is the assessment and the plan. The assessment is what you think is going on with the patient, and the plan is what you're doing about that assessment. And in fact, when people do these system-based notes, their first blurb is the assessment, which is just a rehashing of the HPI, which is also very annoying. The HPI is the story of the patient that brought them to you, and then your assessment is your analysis and comprehension of all the data, the patient's physical exam, the patient's presentation, the laboratory studies, the diagnostic imaging studies. Everything is all collated together and you come up with a diagnosis. Respiratory failure, secondary to pneumonia and COPD exacerbation. It is dependent on invasive mechanical ventilation. They also have acute kidney injury. They also have septic shock from the pneumonia. They also have altered mental status and metabolic encephalopathy from the pneumonia. That's your assessment. These are diagnoses. And then your plan refers back to the assessment, and you go with number one. We're continuing full vent support. Number two, we're titrating vasopressors to treat the shock. Number three, we're giving empiric antibiotic therapy. Number four, we're resuscitating with crystalloid and monitoring the kidney injury with serial lab studies. That's what you're doing. This system-based note, it's gobbled. It just clouds the picture. And I know when we're in training, we want to be comprehensive and we don't want to miss anything. But that's not how doctors think. No physician that I've ever visited for myself or my family or anyone else ever gave me a system-based breakdown of what's going on with me. They just tell me your A1C is fine, your blood pressure is great, and maybe that is system, but they say, if there's nothing going on, that's nothing going on. Or you have papillary thyroid cancer, which is what I had. He didn't go through all the systems, right? He just told me, you have papillary thyroid cancer and we need to do surgery. That's it. Full stop. Done. And then the other thing is, say, for example, it's DKA, okay? Diabetic ketoacidosis. That's in the endocrine section. And typically people put the endocrine section way at the bottom of the systems, right? Because brain is always first, which it should be. So now I have to scroll down through your note to go and to figure out what's going on. And it's a lot of times when I look at the system-based note, I have no idea what's happening. What are you doing? What's going on and what's happening? But they tell me, but that's in the assessment. But then stop there. Why do you rehash the HPI, which shouldn't be? It should be less than the HPI. It should be shorter than the HPI, because they go, this is a 55-year-old man with a past medical history, blah, blah, blah. They're just rehashing the HPI. Don't do that. We know that already. Okay, it's in your note. If I want to know the excruciating detail of what happened last week at the picnic, I'll look at it. I'll read it. What I'm looking for is what's your assessment and what's your plan. And so if it's DKA, okay, it's way at the bottom. Or say it's urinary obstruction from prostatic hypertrophy, right, that's causing a UTI. I got to go all the way down to the IDGU section of your system-based note to figure it out. And that's discourteous. That's not how a physician thinks. The physician, yes, I'm thinking in my brain system-wise and going through and everything, but my documentation should reflect my medical decision-making. And the new rules encourage the medical decision-making. What's medical decision-making? It's your assessment of what is going on with the patient and then your plan to treat that assessment. This system-based, and then what's even worse is I'll have residents present, when I'm doing a night shift, telecritical care night shift, then they'll present to me and give me the plan per system. And I always stop them. Stop. I tell them, stop. No, when you talk to a patient, are you going to tell them, doc, what's wrong with me? Well, let me start from the top. No one does that. And then they all laugh because they know I'm right. They know that it sounds silly to say it that way. So then don't present to me that way. Tell me, here's what's happening and here's what I'm going to do about it. And I always want to teach my trainees to be like that because that is how they're going to be, as whether it's her hospitalists, whether they're specialists, whether they're primary care physicians, it doesn't matter. The system, it's just, again, I know it's trying to be comprehensive. You don't miss anything, but it's a very muddled way to present, and it's a very muddled way to document. And again, it just doesn't, it's not conducive to us being diagnosticians and then healers based on the diagnosis. So please stop with the system-based note. It's not just trainees, it's colleagues of mine across the country do the same thing. And I can't stand it. The new documentation rules, like I said, really, really emphasize there are some quirky requirements. And at the end of the day, it really focuses on us trying to, and I love the new rules. They're trying to minimize the documentation burden and focus on on us being doctors and APPs and clinicians is assessing the patient, knowing what's wrong, and then fixing what's wrong. And you can make a comprehensive, well-written progress note that meets all the rules in literally 3 or 4 inches, not 10 pages, which is what we're doing now. So please stop with the system-based notes. It's so annoying. Thanks everybody. Thanks everybody for your time and attention, and we'll see you next time at Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.